Oh, thank you very much for the opportunity to speak and present some of our results from the work that ANZMES has funded through the project grant we were awarded last year. So we were interested in looking at food insecurity in people with ME/CFS or long COVID. And this was very much a joint piece of work by myself and Kahu Rangahau Dey. And there was also a number of other people involved. So Josie Butler is somebody with lived experience of long COVID who was really instrumental in helping us do the work. And we had a student, Taylor, who helped do some of the analyses, and my daughter as well, Isabel, who has got experience of being a carer for myself when I was less well. Huge thanks goes to the participants who took part in our survey. Obviously, we couldn't have done the research without them, and obviously a massive thanks to ANZMES for funding. So when we proposed to do this, we thought we wanted to find out how common food insecurity is in people with ME/CFS and long COVID. So we designed a survey and we piloted it, and we found that actually affordability, which is how in New Zealand we often measure food insecurity, is actually only one tiny part, and people had so much else to tell us. We pivoted a bit and we also started looking at other factors. So we designed a study to look at nutrition and the difficulties of food preparation and how people cope with the challenges of nutrition while having a chronic illness. So we redesigned this survey and made it available through an online platform through Qualtrics, which was available from May through to September this year. We had 334 people who provided at least answers to some questions. Some people left some questions blank, which was an amazing response. We were delighted with that. And we were particularly pleased that people, well, I say pleased that there was a range of severities. Clearly, we're not pleased that there are people with severe and very severe illness, but it's very important that we hear their voices, and often in research they are left out. So, it's great to see that we had over half of our participants had moderate illness, and a chunk, sort of about, I think it was about a sixth, had severe or very severe ME/CFS. Most people identified as just having ME. Some people had ME and long COVID, and a small number said they had long COVID but didn't identify as having ME. And that was, we asked about people about whether they had had doctor-diagnosed illness or had diagnosed themselves or a different health professional. So that includes anyone who had made that diagnosis. Most of the respondents were European or New Zealand European, but we did have 6% of our respondents were Māori, which was great again. I'm not going to present the Māori non-Māori analyses because we haven't quite finished doing that, and we want to make sure that they're done carefully and interpreted correctly. So that's an analysis that will be coming down the track. I guess this is the sort of headline finding that half of our participants experienced cost-related food insecurity in the past 12 months. So in New Zealand, there are 8 questions which are used to define food insecurity, and the first 6 relate to the cost of accessing food. And these are the first 6 here. So we've defined food insecurity as people who sometimes or never are able to afford to eat, or sometimes or always, because of cost, have food run out, eat less variety, rely on others, or use food grants or food banks. So people who said sometimes or always to one of those, if we added them all up together, then half of people said that they experienced food insecurity. But so then we wanted to look by severity, how that differed. So again, we asked people to identify at the point they filled in the survey how severe their illness was. And as you can see, going from mild to moderate to severe, then the level of food insecurity or the barrier of cost to be able to afford food went up. Among the very severe group, then as you can see, there's quite a different pattern, and that's probably not really surprising because many people with very severe illness are either being tube fed or getting their nutrition in a different way. We then wanted to look at each of those questions individually. So we broke them down, and you'll remember that first question was phrased in the survey, and that's because we used the standard questions as I can afford to eat properly. But here I've just ordered this so that what we're looking at is people in the blue bars who often can't afford to eat properly, so that it matches the other bars as well. So the people we're worried about are the blue bars, and to a slightly smaller extent the red bars. So we can see there that this is where half of people say they can't afford to eat properly. About a third of people say that food runs out regularly because of cost. Nearly half of people say they eat less because of cost. Over 2/3 of people say the variety of what they eat is limited because of cost. About 40% of people say they rely on others because of cost. And about 1 in 5 people are using food banks or special food grants because of being unable to afford food. So these are really, I find, very, very startling results, and obviously very depressing. We also gave an opportunity for survey respondents to add in their own thoughts about their experiences. And I think these, again, are very depressing examples of how much people are struggling. Sadly, food is a luxury item. At times I go without hot water and heating so I can afford to eat. I feed my daughter and not me, just so I can afford the things she needs. We then asked people about when was the time they found accessing food hardest, and someone said, when I had $10 a week to feed myself. Someone else talked about being bedbound, unable to shop or cook, and unable to get to the door for deliveries. So the challenges that people are facing are not only about cost, but also about the logistical aspects of being able to access food. There are fruit and vegetable guidelines that we're all meant to be eating. So these are, oh, sorry, I've just seen Kahu Dey joining. Wonderful. So these are eating 2 or more servings of fruit per day, or 5 or more servings of vegetables per day. And only 20% of people with ME/CFS or long COVID could meet the fruit guidelines, and about 15% could meet those vegetable guidelines. So people are really struggling to access healthy diets. And again, when we look by severity, then it is the people who have got severe illness who are struggling most, it seems, particularly in terms of eating fruit. So only 10% of people with severe illness are able to meet those fruit guidelines, and under 10% with severe illness being able to meet the vegetable guidelines. And again, we had people talking about, describing to us what it was like. Some people talking about we're on special diets. So this is the respondent and their partner. We can never afford fruit and veg, except for some frozen veg. Someone else said, I'm no longer able to go to a supermarket in person as it causes too much PEM, post-exertional malaise, and order almost everything online, barring occasional help from friends. I miss fresh fruit and vegetables. And someone else gave the example of just trying to eat. That was all they could try to target rather than fruit and veg at all. I try not to stress about meeting nutritional needs. My priority is just to be able to eat. On very bad days, I'm too tired to chew food or drink, so just eating is the best I can do right now. We then asked people about where they were kind of making compromises. So obviously the cost of food is a big issue. So we asked about whether people had to reduce spending on other things to be able to pay for food. And about 2/3 of people said yes, that had happened in the last 12 months. And a slightly smaller proportion, about 55%, said they had spent less money on food just to be able to pay for bills and other expenses. So obviously there are trade-offs that people are having to make, and these are not trade-offs between food and luxury items. These are the basic necessities of life. So paying for rent, paying for bills. And again, it seems like people who are moderate and severe are the most affected, which is probably not surprising. But everybody is reducing spending to pay for food, and spending less on food to be able to pay for other things too. We then asked people about what kind of deliveries they were getting if they weren't able to get out. So about a third of people were getting what we termed ingredients delivery, so typically a shop, like a countdown delivery. And about 1 in 5 people were getting prepared food deliveries. So these, when we looked at it, were typically not takeaways, and a lot of people were relying on the soups delivered by ME Respite, particularly in Auckland, where those were available. So about 50% of people with severe illness getting supermarket deliveries, and about 1 in 3 people with severe illness getting deliveries of meals. And of course, that comes at a cost. We also looked at where people were getting help from. So a lot of people relying on family. Without the support of broader family or food banks, I would have even more health issues. Family have to provide food and other basic living needs for me, otherwise I couldn't afford to exist. My parents and other family members give me food. If my husband hadn't been able to work and keep a garden and a few sheep, we would have struggled. But as I said, many people were also relying on charity, and particularly the work done by ME Respite. I had to rely on soups delivered by ME Respite charity as I was unable to cook meals and couldn't afford to purchase microwave meals. I am bed tethered or housebound, so I can't access community free meals, food banks or food pantries because none deliver. I do get soups and other items when they're available in West Auckland through ME Respite. This was life-changing. Someone else said I relied on food grants from the Salvation Army, friends and family to get food. My CFS was bad enough that cooking was often undoable. And someone else talking often about getting food from the food bank. We asked people about other coping strategies, and I really struggle with calling this coping because to me these are signs of desperation. I buy things on special because that's what I can afford. Often the food is off or spoilt and it would make me ill. I've had food grants, I limit my heating, I'm often cold as a result. I've considered foraging, but I don't have the energy. I eat 1 meal a day at most. Someone else says they eat mostly baked beans. And someone else says I've considered shoplifting groceries. So people are really very stretched, and I think at the end of being able to cope for many people. And of course, it's not just the actual cost of food. So the delivery cost of supermarket deliveries is an issue. So this person says this has been a huge barrier, resulting to having to buy less nutritious food because it's cheaper just to be able to afford the delivery cost. Other people talk about having to buy alternative foods, so having sensitivities associated with their illness that means that they need to buy, for example, gluten-free food, which is often quite expensive. And other people talking about the additional costs of medical help or personal help that I need. And this person says, I don't feel like I count. I've been swept under the rug and forgotten. Cost is also a barrier to people trying to improve their own health. Often people are recommended to have supplements. This person says, I can't afford the supplements that my doctor recommends. Somebody else says, I'm unable to try diets such as low histamine my doctors recommend for my illness, but I can't due to cost. Other people talk about focusing on supporting my body to deal with the illness, but I can't do that anywhere near as well as I used to due to food cost increases not being matched by benefit increases. And someone else sums it up by saying, it would be a privilege to eat as my doctor recommends. We then asked people about experiences that they had in relation to eating because of their symptoms rather than because of cost. So there were a small proportion of people who reported having a feeding tube, about a third of people relying on meal replacement bars or shakes, and a similar proportion of people who say that in the past 12 months there are times they've been unable to eat because of symptoms. Then the fourth bar along, about 2/3 of people saying I eat smaller amounts than I would like because of my symptoms. Other people saying I skip meals because of symptoms. And definitely quality and variety is something that a lot of people are compromising on, again, because of their illness symptoms. So unsurprisingly, all this compounds to resulting in a huge amount of stress. As I mentioned, there were 8 questions where we typically measure food insecurity in New Zealand, and those first 6 were about cost, and the last 2 are about stress. So these are questions that are used in the New Zealand Health Survey regularly to try and understand what's happening on a population level. So about 60% of people say, I feel stressed because of not having enough money for food. And about 70% of people say, I feel stressed because I can't provide the food I want for social occasions. But when we looked at our data, then it was more than just stress. People talked about the guilt, the shame, and the stigma. If I'm unable to afford decent food for the week, I'll go without meals rather than ask for help. I'm too proud to ask for help from the neighbours, although the lady next door checks on me regularly and sometimes brings a container of soup or a bowl of chips. My family provide for me, but this leaves me feeling guilty that I can't contribute more, both to purchasing the food and its preparation. This is such a heavy burden of guilt that I carry. So I think in summary, then, we've demonstrated that food insecurity, so both cost and accessibility and preparation, able to access a nutritious diet, is a significant issue for people living with ME. And I think that there are definitely policy implications that arise from this, and we're sort of working on how we can start engaging with policymakers to try to make a difference for some people. So, yeah, very, very interested to have kind of a wider discussion around this. We'd love to kind of work with ANZMES on this. I think that would probably make it a much more powerful outcome, or if we can use our evidence and work with the advocacy of an organisation like ANZMES to try to influence policy. So that is the first part of the talk, and then I was going to go on to talk about the ME registry. So I'll just take a little drink of water and then I'll continue.
Could I maybe jump in with some questions around that first part?
Absolutely, delighted to. Yes, yeah, of course. I can see that Kahu's online as well, so she's also able to answer the questions.
Kahurangi, thank you for joining us as well. So, I really appreciate this research that you've done, and it's actually quite sobering to see these results. And I think it's wonderful also that you were able to have that flexibility to redesign it when you saw that what you were initially wanting to look at was different from the lived experience and what people wanted to explain. So that's wonderful. Can I just ask, did you measure the experience or the results against a household income, or whether people were on benefits? Did you look at that side of it, or was it just what their experience is?
That's a good question. We have collected that information. So we asked people about their weekly income and their household income, and about the number of people living in the house, which obviously makes a big difference. But we haven't completed those analyses yet. But yeah, that would be very, I think, important to do.
I think it just adds to the picture, doesn't it? That is, that if we're looking at it, are these people predominantly reliant on government benefits, and is that why? Because there just really isn't enough money. Because I know just in this last week, an experience of someone I know who has $7 left over because rent is so high, and that's to pay power, phone, food, $7 a week. And it's not sustainable, so now she is honestly at a loss as to what to do. And so, and so I'm going to try and help if I can. But basically what WINS have said is she's capped out at the amount that she can be given. So that's that. And so my concern is, what can we do with these results? So is future research also looking at health and premature mortality cost of this situation, in regards to when does it become undernutrition or malnutrition for these people? And are we looking at this for, quite a large subset of our community, that this is a serious concern? Is that something that you would consider looking at in regards to a sort of public health lens?
Yeah, no, it's a very interesting idea. I'm just sort of trying to think on my feet quite how we could do that. It's really tricky because we're so limited by the lack of good data. So we can do surveys like this, but of course the people who answer the surveys tend to be people who are able to. And like I said at the beginning, although we had a proportion of people with severe illness and very severe, so other people filling in the survey for them, then you don't necessarily know if you're getting the true overall picture. But how we would be able to look at nutritional status, I think, would be quite difficult. But I'd be really interested in trying to do it. But I just can't think right off. Yeah. Have you any thoughts on that, Kahu? Kahu is the nutrition expert in this. So.
Yeah, well, and I think that's kind of where I'd like to be heading to. You know, that was our hunch, really, that you know there was a real malnourishment kind of impact happening in this group. So yeah, we're limited by funding and but yeah, no, definitely, it's definitely something that I'm interested in trying to figure out. Yeah, thank you very much. Sorry for jumping in here, but Mona and I have worked really well together, I feel, on these kind of projects where I have the interest in food and Mona has all these fabulous skills about how to pull together a project. So yeah.
No, it's wonderful. I mean, what you've done so far with this project is so, like I said before, sobering, and it really highlights how dire the situation is for our community, for so many of them. I mean, if you say that it was about half of them, and if we were able to generalize that out to the larger population, that's a real concern, isn't it? And that's, as you mentioned, Mona, with policy. How do we explain this to the government and have it something that needs to change, you know, and whether that is more supports in place, more of that. I mean, because it seemed like people weren't using the food grants as much.
I think the thing about food grants is, like you just mentioned, sorry for jumping in.
No, just go ahead.
We're having a conversation now.
Yeah, absolutely.
They are really limited, and they also are really hard to apply for. Just kind of I'm not sure about your community, but I think that it would be the same. You have to go in there in person. You have to make an in-person application, and you have to provide kind of evidence of your current state, which often means gathering a lot of, or having in one place all these documents to support your position. It's really, it's dehumanizing. It's a really awful process, you know, and often people don't do it because of that, because it's just an awful experience. And they're not always approved, you know. Sometimes they get declined, and like you said with your friend, there's only a limited amount that you can apply for, and basically once they've done that, they're told that, you know, food banks are where you need to get your food now, you know, not as callously as that, but that's, yeah, people are told that the government can't help them anymore. So it's just, yeah. I mean, I would be really, really happy to put together that kind of advocacy, you know, that kind of a policy brief around, extending, food grant eligibility or criteria for socially vulnerable groups.
I think that's hugely important, because, you know, even they're just having to do it in person rules out all our very severes and a large portion of the moderates who are housebound. No, that would be wonderful. I'm sure, as Mona said before, that, you know, joining together, ANZMES and us and the two of you, and getting some important advocacy out there to the government to see if we can make some change, because they may not even be aware, because they're not doing the tracking either. So they may not be even aware of how dire the situation is. So
yeah, and I guess the other thing Oh no, so I just wanted to also bring up food
Yeah.
banks. You know, I never want to sort of suggest that we should be feeling people should rely on food banks, because that is not a sustainable solution. But the issue of not food banks not being able to deliver seems to me such a huge deal. You know, if people are unable to afford food and unable to go to, you know, what is an amazing offer of free food, then yeah, I mean, I don't know enough about how they're set up, but is there something we could do there, do you think?
Yeah, I mean, I know some of them have a delivery service, but I mean, just recently I saw an advert for one of them asking for drivers. So they're obviously, in short supply.
Right.
So
Okay.
yeah, that it's almost like that's a whole nother arm of the operation, isn't it? Is getting it out to the people, which is what we learned in COVID as well, when people were having to distribute food out.
Yeah, and that my sort of understanding is definitely in Wellington there aren't deliveries not part of food banks per se operations, but they do often have volunteers who will help out doing that kind of thing. So it's just, that also is unreliable and ad hoc, so yeah. Yeah, Mona, I think we're kind of like this chat, they're really good to hone in on where the sort of policy recommendations could be. Hey.
Yeah, no, it would be really good, because I think they're quite simple and straightforward. You know, it's not like we're saying let's redesign a health system. It's really basic stuff, isn't it? So
absolutely. Well, thank you so much for that.
Wendy? Can you hear me okay?
Yeah. Yes, we can.
One of the problems that we came up against too is that one place would give so many free parcels, and then there was a compulsory budget advisor sent out, which is just really demeaning, and our lot, they haven't got the money to start with, and they haven't got the energy, and I just thought that was so tacky.
Goodness. So that was after accepting food bank parcels.
Then they think you're not budgeting properly, so they come out and give you financial advice. Yeah,
and that's potentially part of the funding criteria for the food banks. Having to say that they are working with people, because that's the rhetoric around it, that it's money mismanagement, and I mean that's really my interest in this sort of aspect of food security, is that it's we're a rich democratic country. It's not money mismanagement. It's it's the lack of income, and
absolutely. Thank you. So I just thought it might be more seamless to, to talk about it now and then move on to the registry.
Absolutely. Yeah.
Thank you.
That was really great conversation. Thank you. So when we first applied for this funding, we thought, well, if we're doing a survey, how about this would be a great chance to see if people were interested in setting up an ME registry. So at the end of the food security survey, people were given the option to be redirected to another survey, so the food security one was fully anonymous, and there was no link that we can make between that one and a place where people could leave their personal information just to say they were interested in being part of a registry. To cut a long story short, it was not a great success. We had about 250 people or something giving their names, which was wonderful, but we've got a real concern if we made that public, that could be taken in completely the wrong way. So alongside that piece of work, then I had also a small bit of funding from the Health Research Council to talk to key stakeholders about what the point of a registry would be. So I thought I would just present the results of those to you, because they are quite interesting, and I think do emphasise the need for a registry. So people had grand ideas about what could be done. I was just thinking all we want to actually do is count people, just to understand the prevalence. But then other people started talking about risk factors, and we could start looking at all these different other factors that we could relate to prevalence and severity. It was definitely identified as being, it could be a resource for future research. Some people identified it as legitimizing the illness. So, sorry, I should have been really specific. This is about people, we set it out to be about people with ME or ME and long COVID. But for people with long COVID but without ME, there is a long COVID registry. So we said that those people would not be eligible for inclusion in an ME registry only. And there was definite interest in looking about ethnic differences and whether we could look at people with ME and do an ethnicity breakdown. So lots of ideas about why it would be really good to do. Quite a bit of discussion about who could potentially own or host or look after a database like this. And I think most of the thoughts were that if it was based at a university, that would be the best place for it. There were, I thought that ANZMES would be kind of the obvious host, but people from ANZMES themselves said no, that might be perceived as a conflict of interest, although I'm not sure necessarily that would be true. Other people said there was a suggestion that ME support might be a useful place, a useful home for it, but I think the feeling was that they probably weren't quite ready and it wasn't their main area of interest. And then we did talk a bit about the idea of it being hosted by a public service entity. For example, the Health Quality and Safety Commission hosts the Major Trauma Registry. So again, that's not exactly an illness. It's kind of a collection of events that result in major trauma. But it's got its home at the HSRC, and people can access the data through there, and they have got a very careful way of making sure that's available. So to me, that probably would be a good place. But at the time we were having these conversations about sort of 4 to 6 months ago, that I think people were feeling like the public sector was in such a disastrous state that now is not the time to be exploring that as an avenue. We talked a bit about governance, whether there was need for a governance board. I feel like there certainly would need to be, and it would need to be independent of people who were either collecting or using the data, with a variety of people represented on that board, and very clear rules around access, making sure that people were certain that the data were kept secure and only being used for legitimate reasons. So that's quite a lot of work to set up a structure around that. So I think that again, just maybe think really carefully about, if we're going into this, the kind of infrastructure we need to make sure that it is carefully done and sustainable. And I guess the biggest issue, which was demonstrated by the small numbers of people who were interested in taking part when we put it out through the survey, is where would we actually get people from? And I think that it was Warren Tate who cautioned me really carefully to say what we don't want to do is have a registry which undercounts people significantly by factors of probably hundreds, if not potentially even thousands. So again, I'm very a great admirer of his work, and I thought that was a really, really important thing, that we need to think carefully about recruitment. We would have to make sure that we had links across the primary healthcare sector to make sure that people were being included. Now, we know that there's significant underdiagnosis of ME. So although I think we should definitely make it open to everybody who identifies as having ME, I think we would have to make sure we were capturing the vast proportion of people who have had a diagnosis. So I know there has been work done looking at trying to identify ME in the IDI, but that doesn't really only picks up a really small proportion of people. So I think primary care is the place where we'd have to have those really important relationships to make sure it was working well. And obviously funding is an issue. It's not just the setup, but it's the ongoing and sustainability. And I think that's really hard to try to get. People who fund health research don't necessarily want to fund something which is essentially infrastructure. The benefits would come significantly later than the investment. So the investment has to be upfront for any kind of benefit down the track. And I think that's probably where we're going to face the greatest hurdle. I think probably all the other hurdles that I've identified are could be overcome with adequate funding, but my concern is that it seems unlikely at this point, given where research funding is at the moment in New Zealand, that this is ever going to be a priority for the government. So we did then begin to talk about specifically what we might like to collect, but I think that probably is almost a sort of a wish list, because at the moment I think it feels unlikely that we're going to be able to create something which is sufficiently includes a sufficient number of people to make it worth doing, so that it can't be sort of misused and used to say, well, ME isn't something that's important, so we're not going to invest in. So I feel like that's a very depressing way to end, and I'm sorry about that, but it is the reality at the moment. And I will send a message to everybody who did share their personal details to explain this when I've got it written up properly, that it wasn't that we don't appreciate what everybody did share, but I think the risks are at the moment greater than the benefits to do anything with that. But again, very, very open to discussions about that and thoughts about what people feel about that, because I know that it was something that ANZMES were particularly interested in when we did put in that original proposal.
Oh, absolutely, because obviously it will help with understanding prevalence data, but as obviously Prof. Tate said, yes, you don't want to underreport that prevalence. And it's interesting just to go back to clarify what you said at the top of it with ANZMES saying that potentially a conflict of interest. I think that was more really around if it was to be used for research purposes in the future, and then the concern around are we, the perception that we might be controlling it, but also we don't have a secure server in that sense, the way you would need for ethics approval for research and that kind of thing. So that's why we were thinking the university, but I like the idea of HQSC if that was possible too. It's a shame that the risks outweigh the benefits at this point, because it's something that I think is invaluable. You could.
I agree. Yeah, I totally agree.
Yeah, like the understanding we could gain from it, and the way that could help people in the future with advocacy efforts and hopefully policy changes and things would just be immense. But it's, as with everything with all of us, with career researchers and with non-profits, it's all about funding, isn't it?
Absolutely, and it doesn't mean that I'm not going to continue sort of chipping away, but I think to me probably what we're talking about is maybe in about, I suspect, between 3 to 5 years, then primary healthcare data is going to be collated into one. So originally then the last government started that process. The current government have continued it, although they have significantly cut their data and digital teams at the Ministry of Health, but they still say that's what they're planning to do. So I think that is a potential. Once we have a collection of data, in the same way we have a collection of hospital level data, if we have that at primary care, I know that'll still be an underestimate, because people who haven't been diagnosed or the diagnosis hasn't been coded, which I'm certain is also happening. But despite those, if we could at least get a suggestion of how many people have got a coded diagnosis, that would be a start. And so, yeah, I sort of feel like that's probably where we're heading, but always interested to have conversations, with people about this before we get to that stage.
Absolutely. Let's keep the dialogue open. Well, thank you so much. It was wonderful to hear that update and such important work. So thank you so much for your interest in wanting to know the information as well, Kahu and Mona. Really appreciate it.
Oh, thank you. And thanks for the opportunity to share that with you.
Yes, and I would just like to say thank you to ANZMES. We are incredibly appreciative of the opportunity to do this piece of research. It has felt really, really important, and just really appreciate the opportunity. So yes, in this terrible funding environment for researchers, we are incredibly grateful for what you've done. So thank you, ANZMES.
Ngā mihi, thank you.